Idaho Matters podcast is brought to you by St. Luke's On-Demand Virtual Care, which allows patients to see a provider from their home using a computer or smartphone with on-demand care for common ailments, such as a cough, sore throat, or a sinus issue. More information at stlukesonline.org.
Hi, I'm Charlie Hunt.
And I'm Jackie Kettler. We're both political scientists who also love to gossip about political scandals.
In Season 1 of Scandalized, we told the stories of some of our favorite scandals from across American history.
While we work on Season 2, we're dropping 5 brand new bite-sized episodes to whet your appetite.
Listen to new episodes of Scandalized starting Monday, September 29th at boisestatepublicradio.org or wherever you get your podcasts.
From the studios of Boise State Public Radio News, I'm Gemma Gaudette. This is Idaho Matters. A major medical breakthrough is offering some hope for families battling Huntington's disease. Scientists have developed a treatment that targets the faulty gene at the root of this disorder. Now, early trials show that it can slow, in some cases, even reverse symptoms. Now, while more testing is needed, experts are calling this the most significant advance in decades for Huntington's patients. Dr. David Pate, the former CEO of St. Luke's Health System and the co-author of the book, Preparing for the Next Global Outbreak, is here today to talk to us about that and, of course, other public health issues. Hi, Dr. Pate.
Hi, Gemma.
And remember, folks, if you have a public health question, send us an email, idahomatters@boisestate.edu. So, Dr. Pate, can we begin with you just telling us what is Huntington's disease?
Yes, this is a genetic condition. And it is a very strong genetic condition tied to one particular gene called the Huntington gene. And if you have a parent that has Huntington's disease by virtue of the fact that they have the gene, then any of the children would have a 50% chance of inheriting it. And unlike some genetic conditions where you need both genes to have the disease, here you only need to inherit one. So you could get a normal one from one parent, abnormal from the other, and then you are going to develop the disease. And what Huntington's disease is that because of that abnormal gene, you make an abnormal protein in the cells of your brain called neurons. And that abnormal protein is so abnormal, it is toxic, and it eventually kills the nerve cells. Once enough of the nerve cells die off over years, then you begin manifesting signs of the disease. And we typically see people begin to manifest the signs of disease in their 30s and 40s. And then typically they die in their 50s and 60s. And basically what it is, it's kind of almost it's some features similar to Parkinson's disease. Other features are very different, but the things like the abnormal movements where the person can't lift, say, their arm and their hand and keep it steady without it moving uncontrollably. Other parts of their body, including like their tongue, and they can have rapid, jerky movements, and that can even be some abnormal grimacing and so forth. But in addition to those movement parts of the disorder, they develop cognitive issues and decline, and eventually dementia. Typically, this is a very progressive condition that would end up in people being basically wheelchair bound or bed bound, and it's a very tragic disease.
So with that said, Dr. Pate, can you explain what this new treatment does and why is it considered such a major breakthrough?
So when I was in training, this condition was to be feared, a death sentence. Basically, it meant that anybody that inherited this gene was going to die prematurely, and that they would have the onset of symptoms, basically what should be the prime of their adulthood. And so I never dreamed that we would one day have something that would dramatically improve the disease and perhaps offer us a path to even a cure. I'm not sure if that's possible, but certainly we have a lot more encouragement today. So what this is it's gene therapy. Now, people say the mRNA vaccines are gene therapy. That is not true because they do not manipulate the genes, which are DNA. But this treatment does. So what happens is the places that are involved in the brain predominantly with Huntington's disease are, if you think about your head, you would put your hand at the very middle and the top of your head. So that's the middle location is going to be. But then imagine going all the way down to basically about the base of your skull where your neck is. And that's kind of where the parts of the brain that are most effective are located. So what we have to do is it's a neurosurgical procedure. They have to open the skull and then actually get down to where those parts are, very deep in the center of the brain. And then they inject this gene therapy. What they use is a virus that does not cause disease in humans, but that it can be used to carry a segment of DNA that codes for the normal Huntington protein. And when it is translated into RNA, it interferes with the abnormal protein message being sent from the DNA. And therefore, people make less of the abnormal protein, more of the normal protein. And miraculously, what we have seen as they have, now this is a small study, so it's got to be replicated in more people, and there's still much more for us to learn. But what they saw in these individuals is that the progression of the disease was decreased about 75%. It was much, because we can predictably follow people with Huntington's. We kind of know the rate at which they're going to deteriorate, and we can measure something in their spinal fluid called neurofilament that gives us an indication of how much cell death is occurring. And what they saw is that after these treatments, that the levels of that neurofilament in their spinal fluid decreased to even below what they started out with. So this is just, it's highly encouraging. And another good news is that we believe it would only take one treatment to get the benefit.
Wow.
And that's because brain cells don't turn over as fast as other cells of your body, like your hair, your nails, your skin. So those cells in your brain are actually not frequently replaced. Therefore, once we can make this change in the cells, it's usually going to persist for years, if not decades. And we're anticipating it would not take a second treatment. But that's to be determined in the future.
Mm-hmm. So, Dr. Pate, with the treatment you just described, I mean, could this type of gene targeting approach possibly help in treating other genetic disorders in the future?
Absolutely. So another example, I used to take care of lots of sickle cell anemia patients when I was in training, a terrible disease, and one that usually took these people's lives prematurely, even earlier than Huntington's disease. Often these folks did not live to 40. And so it was a dreadful disease and a very painful disease. We now have cured a case of sickle cell by gene therapy. I couldn't have even imagined that when I was in training. So yes, we are learning so much about how to treat these genetic problems. Now, they have to be, at this point, they have to be very relatively simple genetic problems. What I mean by that, you and I have talked about autism, which is a very complex genetic problem. There's no thought that this is going to take care of autism anytime soon, because it's the interplay of multiple genes and other factors. But sickle cell anemia is one gene. Huntington's disease is one gene. And so we can look at other diseases that have a fairly simple single gene defect or maybe a couple of discrete genetic defects that we could treat. And I think it's very exciting. I think the only thing that I worry will stand in our way of tremendous advances in this field is the decrease in funding of our scientists that has been happening and that you and I have talked about. And we've got so many of these leading scientists that are actually leaving the country to go elsewhere to be funded, or their research is being shut down. And that's the only thing that I think could limit the promise of all these therapies for us. This is absolutely a field that could blow wide open.
I want to turn now, Dr. Pate, to COVID, because my goodness, it seems like so many people are getting it right now. And I guess that is because cases are on the rise and there are two new strains, Nimbus and Stratus. So what is driving the recent rise in COVID cases? Do we know?
Yeah, so it's a combination of things, but one is that what we saw early in the first year or two of the pandemic is that the virus continued to get better at transmitting and spreading to people by increasing its contagiousness, the ability to transmit. What has happened, particularly since Omicron, which first appeared on the scene in the United States in around January of 22, is that now the main strategy for the virus has been what we call immune evasion, which is a bit of a misnomer because the virus cannot totally elude our immune system, but it's getting better and better at getting around it. And so that our immune system is not quite as efficient. It doesn't mean it's not helping. And of course, you want the more immune protection you can have, you want it, but this virus keeps on evolving to try to get around that. And so that's what's been really driving the spread of that. Of course, the virus has also changed in another really interesting way. I remember in late 2020 and early 21, I could not figure out why did this virus not seem to be spreading very significantly among young children, and it didn't. But what happened is it changed, starting with Alpha variant, but it really changed with Delta and then Omicron, to where it's now actually much more efficient to spread among children. And so what we didn't see in 2020, but we are seeing now, is that it, like influenza virus, oftentimes is spreading from schools. In fact, about 70% of household infections occur because of a child getting exposed in school, and then they bring it home. So and with the restarting of school, of course, that's probably helped to fuel this most recent rise.
So with that said, Dr. Pate, should we expect to see cases continue to rise, or, could this wave level off soon? But then again, we'll probably come right into flu season.
Well, right you are. So actually, it looks like this has just peaked. and it looks like it is on its way down. There's still, as you mentioned, knowing a lot of people with COVID, there's still a lot of COVID out there. It's just that it has peaked and now it's starting to come down, which is good. And right you are now probably. Typically what we see with our seasonal influenza is that activity would kind of pick up late in this month or maybe sometime during next month. Usually our peak activity from seasonal influenza is December through February. And historically, although this can vary from year to year, but historically, February tends to be our highest activity month. So, as you know, I typically warn your listeners not to get their flu shots till I tell them, because right now we have very low levels of influenza. Mm-hmm. And the problem is when you get your flu shot, it does wane. And what we want to do is make sure that you time getting your flu shot to when we start seeing the cases pick up, so that by the time it's peaking, say in February, that you're still going to have good protection. Everybody's heard people say, oh, well, I got the flu shot and I still got the flu. Well, that can happen, especially, some of the pharmacies started getting your flu shot, 2 months ago, which, you're just not going to have protection by the time we have a lot of flu. So that can certainly happen. But anyway, that will be coming. But then, of course, what we know is then this virus the SARS-CoV-2 virus will mutate again, and we will see another surge of it and expect to see that. I'm sure before winter's over, we'll see that again.
President Trump announced yesterday that his administration has reached a deal with Pfizer for it to voluntarily sell its drugs at lower prices to Medicaid patients. And the president said that this deal would allow Pfizer to sell direct to consumers on a website that would be called Trump RX. So what do you know, if anything, about how this would work? Because this wouldn't roll out, at least the administration said, not until sometime in 2026.
Yeah, I know very little because the president hasn't put, or somebody at his agencies hasn't put out any information that goes over the details that I can find. So it raises a lot of questions. Look, anything we do to bring drug prices down is generally a good thing. But the reason I don't know how excited to be about this is, first of all, typically in direct-to-consumer websites, generally that is not a transaction through health insurance. And so typically it's more intended for people that don't have an insurance policy, they're uninsured, or they don't have drug coverage. And so it's typically a cash transaction. Even with the reductions in prices, which is good, it's going to help some people at least. I just don't know if it will help most people because it's probably, if it's like other direct-to-consumer plans, then it's probably still going to be better to go through your regular insurance. The other thing is that while it's very, that this could be very, very good news. On the other hand, at the same time, what President Trump has threatened is 100% tariffs against other pharmaceutical companies for drugs that we import. Now realize that 90% of prescriptions in the United States are for generic drugs, and we only make 20% of the generic drugs in the United States, which means we are highly dependent on those medications coming from other countries. My understanding, I don't know if he's postponed it, but my understanding is that tariff's supposed to go into place today, I believe. And if that happens, then that could significantly reduce the supply of other drugs that aren't from Pfizer, which a lot of them are. And then how you and I have talked over the years about how frustrating some of the drug shortages have been. This could be a really big problem. I hope it's not. And we have to wait and see. But so, yes, some good news on this one hand and bad news on the other hand. And I just don't know how this is all going to play out just yet.
I want to talk next about a new study that was published earlier this week in JAMA Internal Medicine. It shows that cancer cases are rising in young adults. So, Dr. Pate, does this new study tell us about what does it tell us exactly about rising cancer rates in young adults?
Right. So, there's been several news lines along this way. First of all, a lot of the vaccine disinformation people are suggesting that there is some kind of turbo cancer, quote unquote, that's being driven by the vaccines. We have zero evidence of that. Zero. In fact, we have evidence it's not happening. And we have never before, it doesn't mean it couldn't happen, but we have never before had any vaccine that has been able to be attributed to the development of cancer. In fact, we now have vaccines that actually prevent cancer, like the HPV vaccine. So that's been one story. But there's another story, and you and I have talked about it, where there does seem to be more cases of particularly like colorectal cancer in young people. And so it certainly caught our attention. So in this study, what they do is they look at it to see what might be going on. Because when you see a rise in cancer diagnoses, just like when we were talking about the rise in autism diagnosis, you have to look at, did anything happen over that period of time? Well, in fact, we decreased the screening ages for breast cancer. You and I talked about that a few years ago. It went down from 50 to 40. And so certainly you're going to catch more breast cancers, early ones, than if you wait till 50. And then we decreased the screening recommendation from colorectal cancer that used to be 50. We lowered it to 45. And so what these authors asked the question is, okay, we've detected more cancers, but is that because there is a overall increasing rate of cancer, in which case you would expect there'd be more deaths, or are we detecting cancers earlier and people getting better outcomes, in which case you would expect death levels to remain the same or decrease? And what they looked at is 8 cancers that have been increasing more than 1% per year. And so that's colorectal, endometrial, thyroid, anal, pancreatic, kidney, and a cancer called multiple myeloma. Now, some of these cancers are very rare, so even a little increase is going to be magnified. But what they showed is that for most of this, the mortality rate has remained flat. The exception was increase. They did see some slight increase in colorectal and endometrial. So obviously that requires more study. This study does not provide us the answers for that. But on the other hand, we've seen decrease in deaths in kidney cancers, and we have seen breast cancers that didn't make the top 8, but they are increasing. That mortality is decreased in half. So that's good news. So I think the bottom line is we need to do more studies. We probably don't have the full answer right now, but the good news is that it looks like probably a substantial part, maybe not all, of this, what is detected as an increase in cancer, may be that we're getting better at identifying those cancers earlier. And of course, when we identify them earlier, there's generally better outcomes.
Well, and that's what I was going to ask you, Dr. Pate, because I have a brother who passed away 9 years ago at the age of 48. He was diagnosed with stage 4 cancer in March. He passed away in August. He was going to doctors for many years because he had all kinds of issues. Never once, up until the end, was he even looked at for cancer because they kept saying, you're just too young. You're too young. With that said, are there screenings that people who are younger really should be advocating for earlier? Because I think right now we're kind of in this place where you have to be your own advocate, in particular if you are younger, when there's this idea that so many cancers won't happen until you're older. My brother didn't get stage 4 cancer in the span of 3 months.
Right, absolutely. And certainly you bring up a good point because there are many factors to the development of cancer. Cancer does take a long time to develop. And the problem is, like you were pointing out, is it in the early phases, it can be advancing and growing without symptoms, and those symptoms might not present till late. So, yes, when somebody who has been previously healthy now has new symptoms that are distinctly abnormal for them, yes, be your own advocate. Make sure that you are seen and evaluated, and make sure that your doctor doesn't take things off the table until it's been closely looked at. And so, particularly if you have a family history, we know family history is very important for colorectal cancer. It's very important in breast cancer. So, especially make sure if you have, and the closer the relation to you, like a parent or a sibling, the more important that information may be. And so make sure that your doctor is aware of the family history, and then make sure that you get a thorough evaluation because there are many other possible explanations. Not everything that causes change in symptoms is cancer, but make sure you get a thorough evaluation so that we can be confident we've identified what the problem is.
So, Dr. Pate, Barbara sent this question in after listening to our discussion on autism last week. And she asked, can you tell us where we can find the Swedish study that you mentioned? And she also went on to say, should we base our care on the findings from just one study?
Okay, great question. So, Barbara, I'm going to start answering your question while you get pen and paper to write this down. So, as to your question about should we base care on one study, that's not what's really happening here. What this study was trying to address is that there had been previous studies that showed a slight correlation of mothers who took Tylenol with children that had autism. And that is what led to the president's comments, I believe. What I explained on the air is that an association does not necessarily mean cause. And what my example is why were the women taking Tylenol? Because maybe it's not the Tylenol, maybe it's what they were taking Tylenol for. And because studies have already shown that fever and pain can be detrimental on the fetus of a pregnant mom. So maybe the Tylenol is just telling us that there's something else going on. So what was significant about this study was a couple things. One, how large the study was. Second, how long they followed these subjects. They followed some to age 26. And then third was how well controlled it was, because what they did is they looked at those mothers that took Tylenol in one pregnancy but not another, so that we could kind of straighten out some of the variables and be able to directly compare these siblings. So here's the answer to your question. Write this down. It's JAMA Network, which is JAMA network.com /journals /JAMA, JAMA /full article /2817406.
Okay. Dr. Pate, Allison emailed in because she said after she heard our discussion last year that if you have a strong reaction to the COVID vaccine, to the Moderna or Pfizer vaccine, maybe try the Novavax COVID vaccine instead. Allison says she did that last year, and I'm quoting her. She goes, "Wow, I felt so much better after the Novavax shot compared to my response to my previous Moderna shots." So now, Dr. Pate, she says, is there anywhere she can find the Novavax COVID vaccine in Boise this year? She's looked at numerous pharmacies, as well as Primary Health Medical Group, and no one is offering the Novavax so far this year.
Yes, you can find it because I just got it. So, Allison, I'm going to talk to you while you get pen and paper. But I got mine at Walmart. So I know they have it. The trick is probably when you were looking, they hadn't received it yet because the Novavax was late in shipping and most of them just were getting their stocks at the end of last week. So check again. But here is the website for you. The company that is distributing Novavax just went live yesterday with a locator. So here it is. It's Nuvax Ovid, which is NUVAXOV.com/vaccine-locator. And it will show you. But I think when I checked it, it was working. I checked it yesterday, and I think Walmart and I believe Costco now has it, but there's a number of places. So I think you can find it now.
All right. Such good advice, Dr. Pate, because when folks have those reactions and knowing that there's a different option really can make a big difference.
Absolutely. And the studies have shown that Novavax is less reactogenic, which is our fancy term for the local side effects you get with the shot.
All right. As always, Dr. Pate, so good to have you with us this week. We've been talking with Dr. David Pate. He is the former CEO of St. Luke's Health System. He is also the co-author of the book, Preparing for the Next Global Outbreak. Remember, if you have a public health question for Dr. Pate, send us an email, idahomatters@boisestate.edu. And that'll do it for this episode of Idaho Matters. Thanks so much for listening. And just a reminder, you can find all of our episodes wherever you get your podcasts.
Sources and methods, the crown jewels of the intelligence community. Shorthand for how do we know what's real? Who told us? If you have those answers, you're on the inside, and NPR wants to bring you there. From the Pentagon to the State Department to spy agencies, listen to understand what's really happening and what it means for you. Sources and Methods, the new national security podcast from NPR.